There it is. All right, we're live. So welcome to Seinfeld. This morning's episode will focus on the non-fat yogurt. So anyone can kind of kick us off. What caught your eye? The episode that you watched.
I thought it was interesting that Elaine, rather than just not eating the yogurt, needed to know the caloric content of the yogurt, and went through this whole process to prove that it wasn't her actions that had caused her to gain weight, but someone else's.
Okay. Let's say that the behavior that you observed and what's identified now is her being focused or perhaps even preoccupied on the content of the yogurt is something that his behavior is repetitive and causes clinically significant distress or impairment, right? So we're going to reframe what you saw and put it in a clinical setting. And now you're the psychiatrist. So you're in your clerkship and Elaine presents to you with that chief complaint. Your initial impression, like where does your mind go in terms of what might be going on there? And therefore, what questions are you going to now ask as part of your psychiatric interview?
I think one thing I might be thinking about is maybe OCD, just to rule it out. And I would ask if she when she has these thoughts, is there something that she can do to like alleviate them, and does she feel compelled to do those? Like, will she not feel relief until she completes that action?
Right. So if you identify that these are preoccupations or perhaps even obsessions, I'm not really sure there's a whole heck of a lot of difference between those two clinical terms. And then the follow-up question of whether or not they induce anxiety and what efforts are made to then reduce that anxiety, especially in the form of compulsive acts, right? What if Elaine tells you that, yes, in fact, these thoughts are intrusive and they are causing me clinically significant distress and impairment. However, no acts, right? There's no action whatsoever. I'm anxious. You have her rate her anxiety on a scale of 0 to 10. She's anxious, but no checking, no counting, no cleaning, no repetitive acts. What now?
I think sorry.
I was just going to say, to my understanding, for obsessive compulsive disorder diagnosis, you need either the obsessives or the compulsives, correct? So if the thoughts are intrusive and impinging on our daily life, does that satisfy criteria for diagnosis?
Anybody have any feedback?
Well, I had a the question the other day.
Perfect timing.
Where somebody was having, I'm sorry to spoil, somebody was having these really intrusive thoughts of like stabbing their mother, and like every single time they saw their mother, they just like really had this vision where they wanted to stab them. It was so intrusive, it was so distressing. They shouldn't stab her mother. The answer was still OCD.
It was, right? So that's our answer, and that's in fact correct. Individuals up to 20% have intrusive thoughts only. About 80% will have both. Right. But yes, if an individual is struggling with intrusive thoughts and they are clinically significant, then the single best answer is obsessive compulsive disorder. And that is certainly something that we could put high in the differential for Elaine. Now, what if the intrusive thoughts, upon further questioning, result in her body image? So she has a distorted body image and food choices at large play a role here, and now we're observing this in as much as she is preoccupied with the non-fat yogurt.
I mean, one thing that I was also considering is like if a patient comes in with a significant obsession or even a preoccupation with like caloric counts or intake or body image. I mean, things on there should be things like eating disorders or body dysmorphia disorder, especially if the evidence that we had was they gained like 7 to 8 pounds in the matter of, I don't know what the time frame was, but it was a short time frame, I believe, which realistically probably wouldn't necessarily occur unless they're eating a significant amount of food and a very non-active, which it seems that they've been moving around, getting up. So it seems that their image of themselves is definitely distorted. And they're feeling that, the blame is to be put on this fact that this yogurt has fat in it, and it's causing them to gain 70 pounds.
I think also, like going back to Irina's earlier comment, like binge eating disorder could be something to explore, just because like she identified, instead of like acknowledging that she was gaining weight and not eating the yogurt, she went to these great lengths to kind of externalize and blame it on another source other than her behavior. So just wanting to interrogate that and tease it out a little more.
So let's do that. Let's tease that out. What
Like,
did,
I want to know, in the context, because she's like an older adult, but like growing up, how did you like struggle or see your body image? Do you have issues like eating other foods? Do you have periods where you feel compelled to eat large quantities of food, and then in an effort because you feel bad about it, do you go through periods where you abstain from eating food, exercise heavily, use laxatives, etc.?
and let's say Elaine tells you then that while she does purge, that she does not have a distorted body image, and that's verifiable. And therefore, the binge eating and purging behavior is not a form of compensation. With now those embedded in your clinical vignette, you world versus your shelf exam. What's the single best answer here? Is it, and you only have choice A or B, is it binge eating disorder or is it bulimia nervosa? It's binge eating disorder, right? Bulimia would be defined through a distorted body image, and the binge eating and purging behavior, in fact, being a form of compensation, right? When those are absent, we call it or it's more consistent with binge eating disorder.
So do patients with binge eating disorder feel a sense of like guilt after engaging in that binge, but just not feel compelled to purge? Is that how it works?
Well, the compensation is from the body image, not the action of binging. Yeah. So the binge eating and purging, you could clump together, and both are compensation for a distorted body image. That's defining of bulimia. All right. Binge eating disorder is just that. It's binge eating that is not the result of compensation because there is no distorted body image. Right. Now, how do either of these differentiate from anorexia nervosa?
So I was recently told
Don't name names.
I was taught by our residents that, and one of the things that, the BMI classification that used to be, sort of, at least in the new world of the world, the trigger for anorexia, no longer exists. So less than a certain BMI. Yeah, it's not, required for diagnosis.
Well, the individual it is required that the individual is underweight, but there are more, I think, exact methods of determining that beyond BMI. And BMI is problematic in general when it comes to measures of weight designations, including obesity. So in that respect, the individual must still be underweight. And there's the fear of gaining weight despite that. And that's really defining of anorexia nervosa. That is not part of the definition of either bulimia nervosa nor binge eating disorder. Right? The fear is absent, and the underweight criterion is not published as part of either of those two. Right, so that readily differentiates anorexia from bulimia. So if there's weight gain here because of the non-fat yogurt, perhaps in fact being fat or fattening, we're not dealing with anorexia nervosa here. Right. Now, the trick, and just a reminder, is that binge eating and purging have nothing to do with the distinction between anorexia from either of the other conditions. That is, anorexia nervosa does have a subtype, binge eating and purging subtype. So please, in the first sentence of your clinical vignette on your shelf exam, if you see binge eating and purging behavior, do not cross anorexia off your list. Right. So what differentiates anorexia is a fear of gaining weight despite being underweight. Any other observations for Elaine? One more in the differential. What if there's a preoccupation with some imagined defect in appearance other than body image? What do we call that? which of course is not going on here. So instead of, now there's an episode where Elaine comes to believe that she has a big head.
Delusional disorder.
Yeah, so it could be delusional disorder versus body dysmorphic disorder. And this is a tough one, and this is one that is not easily differentiated in either clinical exam or even on the shelf. But what differentiates the two? And the answer is delusional disorder, specifically delusional disorder somatic type, differentiates from body dysmorphic disorder in that one is defined through a delusion, which is an abnormal thought. The other is defined through a preoccupation, which is another example of abnormal thought. Right? Delusions are thought to be more severe deficits in thought content than preoccupations. By definition, delusions are not reality-based and rigid. That is, the individual continues to believe that they have a big head, despite evidence to the contrary. On the other hand, for someone with a non-delusional deficit in thought content, for example, a preoccupation, the individual might demonstrate some insight that allows the clinician to say, well, this is a preoccupation and it's not of delusional quality. It's not a delusion, but it's a difficult differentiation. Delusional disorder, somatic type versus the preoccupation, which defines body dysmorphic disorder. Questions or observations about Elaine? All right, what other characters caught your eye in the non-fat yogurt?
Well, along that line, Jerry and Owen, I guess, also had this theory that there's a conspiracy going around, especially with the question of like Rudy Giuliani when the results of his cholesterol panel came back. That they said, oh, like they got to Rudy Giuliani too. That there's a whole conspiracy going on in New York.
Now, assuming that upon further investigation, their thoughts are not reality-based, because no matter how bizarre it might sound to the clinician, we must always assume, and we must always start the discussion with the idea, with the default that the individual is actually telling the truth, right? And there's what they're telling us is information, not necessarily a form or a product of mental illness. Once there's evidence to the contrary, then we get to say that there's something else going on here. And if whatever that something else is clinically significant, then a psychiatrist, I think, has to render a medical opinion. Along those lines, let's say we've gotten there. For either Jerry or if we want to continue to focus our attention on Elaine, what this brings up is the condition of delusional disorder, right? So the delusional disorder is a form of mental illness, specifically a psychotic disorder, in which the individual suffers from one or more delusions that result in clinically significant distress or impairment, which are not attributable to a larger illness such as schizophrenia or schizoaffective disorder, right? We'll talk a little bit more about those conditions when we discuss our film this afternoon, which will probably focus more on the differentiation between schizoaffective versus schizophrenia. In the non-fat yogurt, if we in fact do see that there is evidence of delusion, I think for delusional disorder, this is the time where we would review the subtypes or the different themes of delusion. And we already spoke about one, we mentioned one, somatic type. There are 4 others. And I believe one of them actually would be the single best answer for either Jerry or Elaine in this case. So generally speaking, what are the different subtypes of delusional disorder? Persecutory, good. Good, 2 more. So that's persecutory and erotomatic. And previously somatic.
It's like grandiose.
That's 3, grandiose, 1 more. Anybody here Seinfeld fans? Yeah, so this is one from the episode, I believe it's the opera, where quote unquote crazy Joe Davola dresses up as the clown Pagliacci. And upon hearing that he doesn't get a ticket, begins to believe that Elaine is actually going out with Jerry.
I'm just forgetting what the word is. I don't.
Jealous type. Jealous type. So the acronym is JPEGs. Right. So it's jealous type, persecutory, erotomatic, grandiose, and somatic. Now, unfortunately, there could be a theme that doesn't neatly fit into one of these artificial categories. And there are a couple of these that actually do appear on shelf exams with some regularity. Right, so anybody know what those are? They usually take the name of the individual that first described them.
Oh, that someone has replaced, those around you, like your closest people have been replaced by,
That,
imitators.
yep. So otherwise known as the imposter syndrome or
Oh.
the body snatcher syndrome, neither of which, that is, those terms are going to appear on as answers on your shelf. And you just described your shelf question. So what's the answer? That's the Capgras syndrome, right? The imposter syndrome or the body snatcher syndrome, the delusional belief that an individual, usually someone close to the patient, is an imposter. Now, there's a variant of this in which the individual believes that a person can actually morph, that is shapeshift. So the shapeshifter syndrome. What's the other name for that? That's Fregoli. It's F-R-E-G-O-L-I, Fregoli syndrome. And the other one, the third that commonly appears on exams in the undifferentiated category is the Cotard syndrome. Cotard is C-O-T-A-R-D, the delusional belief that one is dying or some aspect of them is dying or decaying. So the Walking Dead syndrome. The body snatcher syndrome is basically any alien film in which there's assimilation. And the Walking Dead syndrome is basically any zombie film. You have a question? But there's a question. All right. No?
Just a consult, and then so I was there.
Oh, no, you're fine. Yeah, we have like 7 minutes to go. We're good. Other characters here.
I guess you'll talk about George. He basically got roped into this. I guess initially it was just a lie because he was trying to not say that he was pointing something out to Jerry. Then he basically had to admit that he was having this somatic symptom where he had this issue, and then that led down a line where he was being referred to like orthopedist. He was, saying that he was having symptoms in front of others, his family, even though they denied it. They said we never heard about this.
Right. So the differential here is threefold. When somebody presents like George to the neurologist or orthopedist, number one would be a somatic symptom disorder. Number two would be factitious disorder. And the third and final, the differential, would be malingering. Right. So the first question that the clinician needs to address is whether the individual is making a conscious effort to deceive the physician or the clinician. If the answer is no, let me rephrase that. If there is not evidence, if there's an absence of evidence that in fact is happening, the answer must be no. Right. Again, we're going to set the default that the patient is always telling us the truth and being reliable. If that is the case, your differential diagnosis is basically twofold. There's somatic symptom disorder and a related disorder called conversion. Right. In either situation, the individual truly believes they have a deficit, or their chief complaint is something that is demonstrable. On the other hand, if it is uncovered that they're lying, that they are actually providing misinformation and misinforming the clinician, your differential is factitious versus malingering. In malingering, you must discover some external incentive as to why they are providing that misinformation. Again, the default here will be that they're not, right? That they're being motivated by not something or anything external, but instead internal or subconscious. That's always the default. Once you discover that there's a workman's comp case pending, motivating their behavior, then it's malingering because of that external incentive that you discovered. In the absence of that, the motivation will always be internal, and your single best answer will be factitious disorder. Right? But in either case, they're deceiving you, and they're making a conscious effort to deceive you. Okay. Questions about factitious versus malingering? When you don't discover, or you fail to discover any evidence that the individual is making a conscious effort to deceive you, then your differential is going to be somatic symptom disorder versus conversion disorder. And then, and I think the easiest way at this point to conceptualize this is that conversion is just a variant or an example of somatic symptom disorder. Somatic symptom disorder is when an individual has one or more physical complaints for which no organic etiology is founded. When that physical complaint primarily focuses on voluntary motor and or sensory function, that is a somatic symptom disorder, but it's common enough where the American Psychiatric Association teased it out, fleshed it out, and provided its own diagnostic label. And it's called conversion disorder. Questions about the differential between the somatic symptom and related disorders? We'll review this again. I provide a formal PowerPoint a little later in your clerkship. What's George have then? I'm glad I asked before you were able to ask me.
Malingering,
Why do you say malingering?
if he's doing it for an external benefit, which is to not seem weird in front of this child identity.
Yeah, I mean, if he were to have told the truth, I think he would have been embarrassed that he was nudging Jerry because he was making fun of Lloyd or drawing Jerry's attention to Lloyd. So it's malingering.
I have a question. Do George's parents, when I forget whoever the mayor of New York was, who they were like thrilled that their son was being referred to the mayor of New York's orthopedics? Is that the halo effect?
Halo effect, describe that.
Where someone, because of, I know traditionally it's, feature, like physical features, but I was wondering if status also fell under that. Is like looked at or perceived as good.
I have to look, I don't know. Anybody have any thoughts?
And is it like where you're saying like you're like a pedestal center?
Yeah.
Probably, but again, for those of you who have watched Seinfeld, the Costanzas are complicated.
Okay.
Okay, this is a family and a family dynamic that is certainly at the root of all these maladaptive behaviors we see in an adult George. I think the halo effect is probably part of that, but notice that the person that they're putting up on the pedestal is one of George's, I don't want to say friends, but earlier relationships that demeans George. Right, so this is comparing George in a form of sibling rivalry, that is incredibly maladaptive. And that's consistent with what Frank and Estelle do to their son. Even in flashback, and not this episode, but in several episodes, we see this again and again and again, that George's self-esteem is extraordinarily low. And they're putting Lloyd Braun on a pedestal is consistent with that. All right, that brings us, we're 25 past the hour. Any final thoughts or observations?
We don't see it too much in this episode, but Kramer has very like schizotypal type qualities. You can kind of see some of it, but probably not enough for diagnosing based on the criteria.
Agreed. Now we'll get into the cluster A personalities through Kramer, certainly probably as soon as next week. But 100%, that's 100% right. Kramer will, depending on the episode and depending on therefore the level of stress, pretty much oscillate between all three personality disorders and schizotypal at the very top of the list. No doubt about that. And we'll probably see that as soon as next Friday. Yep. All right, we're going to sign off here. For those following us at home, we're going to get on the next link for cable rounds. See you then.